The third abstract that we presented at the ASCO GU 2021 Symposium was led by Dr. Fadi Taza, and this was an abstract focusing on the PARP inhibitor responses in the BRCA patients. Now, as we know, BRCA is not a monolithic group. It's composed of patients that have mutations in the BRCA1 gene or the BRCA2 gene. And interestingly, in other cancers, such as ovarian cancer or breast cancer, the prevalence of those two genes is roughly equal, about 50% BRCA1, 50% BRCA2. And also the responses to PARP inhibitors in those two diseases also appears similar. So we decided to ask the question whether the BRCA1 and BRCA2 mutations had similar or different responses to PARP inhibitors in prostate cancer, which of course is a different disease. Maybe it has a different biology. So a few interesting things emerged. Number one, BRCA1 is much less common than BRCA2 in prostate cancer. It was about a 10-fold increased prevalence of BRCA2 mutations compared to BRCA1 mutations. So the BRCA1 subset was relatively small. Nevertheless, when we analyzed clinical outcomes data on 123 consecutive patients with either BRCA1 or BRCA2 mutations from a United States consortium of academic centers, we included data from approximately 12 academic centers to come up with that sample size of 123 patients. And what we found was that every clinical outcome that we looked at was inferior in patients with BRCA1 mutations compared to those with BRCA2 mutations. So PSA 50% response rates were about half as often, half as frequent in the BRCA1 versus BRCA2. Progression-free survival was shorter in the BRCA1 versus BRCA2 patients, and overall survival was also shorter in BRCA1 versus BRCA2. So this was intriguing to us. It taught us that in prostate cancer, those two genes are not equivalent with respect to their sensitivity to PARP inhibitors. And then we went one step further. We tried to understand why this happened. And we discovered two things, both of which need to be validated. One hypothesis was that perhaps germline of BRCA1 and BRCA2 mutations are different. In other words, there might be a higher prevalence of a germline BRCA1 versus BRCA2, and we did not find that. The chance of having a germline mutation in either gene was approximately equal. What we did find a difference in was in the proportion of mutations that were biallelic, in other words, where both alleles were inactivated. In the case of BRCA1, a very small proportion had biallelic mutations. In the case of BRCA2, a much higher proportion had biallelic mutations. So that's potentially one reason why the BRCA2 patients might respond better than the BRCA1. And then there was a second interesting phenomenon. We looked at additional gene mutations that might coexist in the same tumors of patients with BRCA1 and BRCA2 mutations. And what we found was most other mutations were not different in between the two classes, but P53 was enriched, was more frequently co-mutated in the BRCA1 patients compared to the BRCA2 patients. So our second hypothesis is that perhaps the decreased efficacy of PARP inhibitors in BRCA1 patients might be because of a higher coexistence of P53 mutations in those tumors.